Well, good afternoon, everyone. It's a real pleasure here to visit with you in the afternoon. I'm Pat O'Gara, and I'm the incoming president of the American College of Cardiology, and I was a member of the writing committee for the 2014 guidelines on the management of patients with valvular heart disease. But we're here today to visit with Dr. Rick Nishimura, who's a professor of medicine and a consultant in medicine and cardiology at the Mayo Clinic in Rochester, Minnesota. Rick, of course, was the guiding force behind the 2014 guidelines, and with Catherine Otto served as co-chair of the process, which I would start by saying took place over the course of 2 years. And in comparison to many other guideline initiatives on behalf of the American College of Cardiology and the American Heart Association, this one was completed from start to finish in a relatively short time as guidelines go. And I think our purpose here is for you to listen to Dr. Nishimura as we kind of walk through the process of guideline development and how he saw this process and what, on a personal level, he brings to the vision of guidelines for the present and for the future. So, welcome, Rick.
Thank you.
It's nice to have you here. I can tell that you're very excited and you're wondering what the next question is going to be.
But I thought I was going to interview you, so can I ask the questions?
No, you can't. And so there will be no negotiations regarding who asks the questions. Of course, members of the audience, I hope very much that if you do have a question, we'd love to incorporate it here as part of our Actors Studio equivalent. But this is really about how to get to the mind of Rick Nishimura. So Rick, let's really start by your telling us a little bit about your interest in valvular heart disease. How did this start?
Well,
Put your arms down.
Put my arms down?
Yeah. Look at the camera.
Look at the camera.
Right.
If you think about valvular heart disease, it really incorporates everything that excites a young person, and young is much younger than we are.
Yeah.
In cardiology, if you think about back when you were a medical student and started learning about hemodynamics, and you started learning about the effect of hemodynamics on the heart, and then the whole concept of taking a patient, performing a physical examination, getting the information from there, going one step further, doing some imaging to kind of confirm things, and finally be able to treat people to make them feel better. I don't think there's anything that outdoes valvular heart disease, and the whole concept of being with the patient, having to think, as opposed to some of the other things we do, and then making a patient feel better. So,
can you remember a particular moment during your medical school training or your internal medicine training or your cardiology training that was kind of like an aha moment for you? Do you remember a specific patient or specific problem that you dealt with?
I think the aha moment is, and I suspect that the young fellows and residents have had the same experience, is that to come fresh upon a diagnosis that nobody else has made before, because you're using your head and you're using your stethoscope, and all of a sudden you can diagnose something that's been plaguing this patient for years and years and years, and then do something about it. And I remember a couple of those patients that we saw in a consulting service, so they were on a surgical service, so nobody ever listened to them. But then you can diagnose them and you can make them better. Yeah. And that was very nice.
Oh, that's terrific. Do you remember what they had in terms of their valve lesions?
One had mitral stenosis and one had aortic stenosis. Okay. Remember that very clearly.
Yeah. Well, let's fast forward a little bit and tell us, if you could, what you do on a daily basis when you're at your day job. So how does valvular heart disease integrate into your clinical activities? A little bit maybe about your research activities as well. So where does valvular heart disease fit in the spectrum of all the things that you're doing?
So I've got a great practice. I've got a lot of physicians who will refer patients to me who have these complex hemodynamic and valve problems. So I'll spend one day just seeing them, evaluating them, working them up. I'll spend the next day in the catheterization laboratory doing some of the kind of the complex diagnostic stuff, and if they need intervention, do intervention at the same time. So it's a tremendous practice.
Yeah, it certainly sounds like it. It seems to me it's a special practice. Is it possible to duplicate a practice like this in a different environment, you think?
I think anybody, so I tell our fellows, I say, listen, when you graduate, you're going to be the person that everybody wants to go to with the patients they can't figure out. And I think any fellow who really puts their mind to it and works very, very hard can have that type of practice.
Great. So you think there's a future for fellows who would be interested in a career centered on valvular heart disease?
Yeah, definitely. I mean, with all of the guideline-directed medical therapy now for coronary disease, we're seeing in the cath lab, of course, that PCI volume is going way down. But I think what's coming up because of the fact that people are living longer, they've got the degenerative valve disease, that the structural disease is coming up and up, and we need to be prepared to take care of it.
Okay. Well, I don't want to lose the thread about training. So one of the questions that comes up frequently, it seems to me, is that a fellow will come to you and say, well, Rick, should I do imaging as my pathway towards developing an expertise in valvular heart disease, or should I be a structural interventionalist and look to a future of being the go-to person for transcatheter valve intervention? So how do you help walk people through that kind of choice?
I think both areas are going to be, well, they're complementary to each other, but I think both areas there's going to be a great need in the future. And it just depends on, you always want to say, you got to pick the career that you do so that when you wake up in the morning, you're going to say, this is going to be a great day. It's like David Holmes. Every day he gets up, he says, this is going to be a great day. And that's what you have to do to be able to pick what you want to do.
Great. Okay. Well, we're going to return to that theme at the end of the interview. And hopefully the mic will come back on and you'll be able to hear what I'm saying. But what I just said was a joke to Dr. Nish. No. Okay. So, Rick, let's look at the guidelines. We have a bound copy here in front to certainly memorialize the product and remind you about what a massive undertaking it was. Tell us a little bit about the history of this guideline. When did the valve heart disease guideline first appear?
It was back in 1998, so that was a number of years ago. Before that, there was actually no consensus at all about how to manage patients with valvular heart disease. So Bob Bono and a few of us, including Dr. O'Gara here, were picked to get together. And we wrote the first one in 1998, or 1996, did some updates since then, 2006, an update in 2008, and then figured out that we really needed to do an update now.
So what do you think has changed in the field of valvular heart disease that would have necessitated an update? So, yeah. But just to sort of make sure that we're all clear on what this is, this was a complete revision.
This is a complete revision, okay. Rewriting the whole thing.
Okay.
And I think there's a few things that have happened. Number one is we have a much better idea of the natural history of valvular heart disease. In other words, with the advent of echo, we can actually categorize people. We can get objective measurements on how severe their valve is and their LV is at one point in time and follow them out sequentially. So we have natural history studies that we never had before that tell us, for instance, the natural history of asymptomatic severe aortic stenosis is not as good as we thought. The second thing is we've got great imaging now. We never were able to quantitate severity of valve regurgitation. We can very reliably quantitate valve stenosis and the effect on the left ventricle non-invasively, and we always had to go to the catheterization laboratory for that. The third thing is that our interventions are much better. Surgery can be done with a much lower mortality and morbidity. And then the fourth thing is we've now got catheter-based therapies so that we can really decrease the threshold to be able to perform some of these therapies. So I think you put all that together with all the studies that have been coming out, and it was time for a rewrite.
I see. So one thing you didn't mention was whether there were any advances in medical therapy of valve heart disease. Have there been any?
I don't know. Have there been any advances in medical therapy, Dr. O'Gara?
I'll take that as is that your final answer?
That's my final answer.
Okay. I gather the answer is no, that was not one of the major stimuli to...
And actually, one of the major changes that was made was we actually took back what we said about medical therapy and some of these other valve lesions. So for instance, we were talking about calcium channel blockers and asymptomatic severe aortic regurgitation. We were wondering about afterload reduction and mitral regurgitation, and the subsequent randomized trials have shown that it actually doesn't work. So we've actually retracted back medical therapy.
So after you and Dr. Otto were asked to co-chair the writing committee, tell us how you went about selecting the members, and tell us a little bit about how you envision the workflow of the document from start to finish.
Yeah, so we got the smartest people in the world. That's why we got you, as well as others, and decided that we're going to kind of proportion out some of the valves, but we're going to do it differently sometime. So Blaise Carabello, and you guys all know Blaise, always talks about guidelines are created in the pub. You know, when a bunch of people get together, they have a few drinks, they smoke a few cigars, they talk about what we should talk about, and you make your recommendations there. And actually, probably the initial guidelines, because we didn't have data, that's what we did. So this time we thought, well, we got O'Gara on, we got to do this scientifically. So before we went further, we had to ask, what are the clinical questions that a physician might have in practice? We're not going to start blabbing away. We're going to ask specifically, what questions do you have when you see a patient? And we wrote those questions down. Then for every question, we said everybody has to go through the literature and create evidence-based tables so that you can't just say, well, I think it's this way. You have to actually have the evidence in front of you. And then from the evidence tables, you can then come up with the class recommendation. And then you throw it out for the committee, who are a bunch of really smart people, to kind of vet and go over and then arrive at a final conclusion. So it's a little different than what we had done in the past, and there were some objections at first because the, quote, experts said, well, we know it all. But I think if you actually follow that kind of more rigid protocol, you actually arrive at some conclusions that you wouldn't necessarily arrive at.
Okay, so formation of clinical questions.
Right.
And evidence tables.
Yep.
On the basis of which to make recommendations.
Correct.
Where does the text come in? What's going on with text that would embellish the recommendations? What did you think about that?
So I'm really glad you asked that question. Because
I'm glad you're glad.
And I'm glad. One of the things we had to address, that because O'Gara is becoming president of the ACC now, he kind of fields all the problems. And if you ask people, do you actually go to guidelines in your practice? They'll say, no, I go to Google. Now, imagine, you know, a patient thinking you're going out of the room and Googling their problem and making a life-threatening decision on the basis of Google. And that's what the majority of people say. We've got this incredibly valuable information. It's been vetted by a number of people. It's been reviewed, yet people haven't used it because they can't get to the information they need at the point of care. And that's when you have to make your decisions. So what we wanted to do, we wanted to write the guidelines differently, not in terms of big books, like, you know, many of us are used to writing, but in what we call knowledge chunks. And what Pat's alluding to is that instead of writing, you know, 20 recommendations and 50 pages of text about something, you would write a knowledge chunk to answer a clinical question. Following the knowledge chunk, if a person wanted more information, you would be limited to a text of about 400 words, no more, with supporting references. So if you go into the new guidelines now, you see they read a little differently, but the reason they read differently is because they're going to be made for the future. so that you can go on your iPhone, you can type in a question, you'll get a knowledge chunk, you want more information, you touch a button, you get this amount of text, you touch a button, you get references. So the whole construct and the whole way we wrote it is different than what we've done in the past.
Have you had any early feedback with respect to ease of use or how to find information at the point of care?
Yeah, so what we have is we have a small prototype that's been developed, and we just have to have people start using it to see how they like it. Mm-hmm. People who've used it thus far, they've really been satisfied.
Great. Well, let's drill down a little bit on the guideline and have you tell us, in your mind, what are the major differences between this document and the most recent document from, say, 2006?
Okay,
what are the big differences?
So I think a few things. Number one is that we've created stages of disease. So you know the heart failure guidelines have this stage A, B, C, and D. Now valve disease is going to be A, B, C, and D. A meaning at risk, B meaning they've already developed valve disease, but it's still mild to moderate. C means it's become severe, and we are now defining severe based on evidence and our trials. And then D is they're severe and they're symptomatic. So C is broken down further into those in whom the left ventricle is compensated, which is C1, and left ventricle is decompensated, which is C2. But I think you can start to imagine now that you can take your patient, you can put them into one of these categories, and then it's much easier to say, well, C1 might be observation, C2 is going to be intervention, D is going to be intervention, and you can kind of, let's say, link the stages to what you want to do in terms of therapy. So I think that's an important thing, is the stages of disease. The second thing is because the interventions have gotten better, and because we know long-standing volume and pressure overload can cause problems that are, you can't predict what the problems are going to be, there's going to be a lower threshold for intervention. And I think as you read the guidelines, you'll see that we'll now be operating on patients that we never operated on before who are asymptomatic to prevent those bad problems from occurring. I think the third thing that is most important, though, is if you're going to be operating on a person who's asymptomatic, a person who feels good, you're not going to make them feel better. So you got to be absolutely sure that it's going to be a good intervention. And in order to assure that, we've put in this concept of heart valve team so that you can get input from all members of the valve team to give education to the patient and have a shared decision-making with the patient, and then a heart valve center of excellence, because a lot of these asymptomatic patients should only be intervened upon if you know that the outcome is going to be very, very good. So I think those are the major changes that we've made in the guidelines.
Tell us a little bit about how the committee worked with participation from surgeons and imagers and anesthesiologists in your mind.
They actually talk to each other, which is very good. Mm-hmm.
So the heart team worked sort of in a microcosm?
The heart team worked within our little boardroom that we were at. But you know, we had some very, very intelligent, collaborative surgeons in there. We had some nice anesthesiologists who gave us their input. We had imagers, we had interventionalists, and we had everybody on the heart team together.
Tell us a little bit about what you found to be the major obstacles in terms of getting the work done and finalizing the product. What would you advise a new writing committee about, and how would you help them navigate the process?
You've got to pick the right people. We had the right people, there's no doubt about it. And you've got to give deadlines, and you've got to give specific instructions. But I wouldn't say we really had a lot of barriers. I think everybody worked together. Our biggest barrier was, so when a guideline's completed and you think it's all done, what you then do is you send it out for review. And the review are representatives from all the different societies and some hand-picked experts from all over the country and the world. And I think our major stumbling block was the fact that we had 1,400 or 1,500 reviewers' comments that were very good, But then we had to almost start all over to assure that the comments were addressed.
Do you think the comments in any way changed a fundamental recommendation?
They didn't change fundamentals, but I think they were very good in clarifying statements and clarifying text so that people were quite clear about what we meant.
Do you think the process worked?
The process worked. Took a lot of work, but the process worked.
Now, a lot of people like to compare our guidelines against the ESC guidelines. And if I'm not mistaken, they had published their valve heart disease guidelines in 2012.
Correct.
Do you see any differences or similarities?
Actually, there's a lot more similarities now between ESC and ACC-AHA than there used to be. And I think it's because we're both using the same evidence. We're using evidence-based methodology. And we've arrived pretty much at the same conclusions.
Tell us a little bit about your plans for derivative products and other ways that you see this particular document finding its way into the hands of clinicians at the point of care. What are you thinking about?
Well, there's the point of care tool where you can just type in a question, get your answer right away. I think, you know, one of the biggest buzzwords at the college meeting today is the maintenance of certification, because we're all, even old guys like Pat and I, have to get recertified and we have to fulfill the requirements. Pat's just written 30 MOC questions related to valvular heart disease, and we've got sessions where you not only can get an update in valvular heart disease, but you can get MOC credit for that. Joyce is going to make sure that this is pushed out to the members, and we can do this on a monthly interval or a bi-monthly interval. So I think there's a lot of new ways that we're going to get this information out.
Excellent, excellent. Tell us a little bit about your next projects, independent of the guideline. Tell the audience what you're working on now and what you have planned for the near term.
Well, fly fishing and skiing would be good. But I think in terms of...
I think it's very important to talk about work-life balance. We can get into that.
No, seriously, work-life balance is important.
Right.
Sometimes you're kind of forced into it, but that's okay. You got work-life balance. But I think in terms of the science, what we need to do is we need to get a method for amassing all of this vast knowledge that's coming out. Categorize it, make it easy to get to. And then, as Pat actually alluded to, find out new, novel ways to get out the information to everybody so that you're aware of what's going on.
When you look out over the field of valvular heart disease, what are the major themes that you would emphasize with respect to future work, near-term, longer-term future work? What's needed from an investigative perspective in the field of valvular heart disease?
So the nitty-gritty, we've got to be able to measure the response of the left ventricle and right ventricle better. You know, we're still using the old-fashioned 2D diameters, and you know, if we can get volumes accurate, reproducible, that would help immensely, and better measurements of ventricular function. I think there's going to be much more in terms of catheter-based therapy for structural heart disease. And then the final thing will be prevention, which we haven't touched yet. Whether or not we can prevent aortic stenosis from getting worse, or this heavily calcified mitral annulus, I think that's going to be important.
Do you think the field is mature enough to support a randomized trial?
Absolutely. And Dr. O'Gara is in charge of the NIH consortium, which is starting to do more randomized trials in valvular heart disease. So the next interview I want is for me to interview Dr. O'Gara about that, because that is going to be the future.
I think we have ample time for members of the audience to ask any question you'd like of Dr. Nishimura, including his favorite number, how he wrestled in high school. I'm sure that there are a lot of issues that you would like to know from Dr. Nishimura. Anyone there? Yes. Could you speak up, please? I can't.
Regarding new staging
Yes.
in the new guideline, what's going to happen to moderate AS with symptoms?
Oh, so actually this was asked before, moderate aortic stenosis with symptoms. This is an area that we have to be very careful about, because in order to write, you know, papers and guidelines, you have to give these cutoff values. And you have to say the cutoff of let's say greater than 4 meters per second is severe, and aortic stenosis less than 4 meters per second is not severe. And that's based on data of thousands of patients. But I think as clinicians, what you have to do is you have to take an individual patient into account and not necessarily use a cutoff. So I think what you're talking about is you might have a patient come with a gradient with aortic stenosis of 35 millimeter of mercury that you would ordinarily say it's moderate, but they have symptoms. Well, that person has severe symptomatic aortic stenosis because that valve is causing them to have symptoms. And we have to get out of this kind of mindset of using one number to describe severity. So this is an incredibly important point, but your patient probably would be described as only moderate aortic stenosis by the cutoff in our guidelines. But if they have symptoms or they have left ventricular hypertrophy, they probably should be treated as severe aortic stenosis because the absolute cutoffs really can't be dependent upon for a single person. That's a very, very important point. Glad you asked
So
that.
stage D.
Stage D.
D, okay.
That person would be stage D. You read the guidelines, very good.
Great. Are there any other questions? Oh, Marcia, please. We'll get you the microphone. Thank you.
I would ask Dr. O'Gara this question.
No.
Yes, I can't resist asking this question. Dr. Nishimura, in addition to being a very distinguished clinician, you are also extremely well known as an educator both at your home institution and for the American College of Cardiology. And I have worked with you many years, and I know that there are many things that you have led and been a champion for at ACC. Among all of those things, what would you like best to be remembered for with respect to your education leadership at ACC?
Do you want to answer that?
I'm not Dr. Nishimura.
Yeah,
Although we look alike. I know.
Yeah, we're brothers. So actually, and Pat and I were talking about, the thing I think that we're proudest of is in the field, and it's not just education, but it's the entire concept of bringing our FITs and our young emerging faculty across that line. You know, there's always been that barrier at the college that it'll only be the old farts like Pat that would get on all the committees. And I think what we've been able to do with some of the programs that we've had is open it up so that the young emerging faculty, the FIT, I mean, this meeting here is just full of stuff for FIT. Did you see the FIT blog with Dana? It's just incredible. So we're getting the young people involved, and I really think that to me would be the legacy that I'd like to say I left behind.
Terrific. I think that's the perfect note to end on. Thanks very much for joining us and meet the master. Thanks, Rick.
Thank you.
Good.